You're watching PCTV Channel 17, proudly serving the Port Clinton City School District community. The following is a production of the Port Clinton High School Digital Media class.
Welcome to Time for Health. I'm your host, Rachel Faw, and we're very glad you've joined us. We hope you gained something from the program that helps you and your loved ones. We want to arm everyone with as much information as possible so we can all make good choices. This is not to take the place of regular medical care, so be sure to include your healthcare provider in on your plans and your conversations. And our topic today is observation versus inpatient status, which sounds kind of weird. But our guests aren't weird. We have Linda Oman and Jody Basak from the hospital. Thank you for being here.
Thanks for having us.
This topic came up because it's something that sort of happens. It's an insurance kind of a thing, a billing thing. It happens kind of behind the scenes, but it's gotten a lot more press. It's a lot more of an issue, kind of been around for a while, but it's getting to be a bigger deal. So we kind of wanted to, our goal is just to get out there in any venue possible to kind of educate people on this topic. So that's why we're here. So Linda, give us a little background on what is inpatient versus observation status.
Well, let me start by saying that this whole discussion started because of something that happened in the Affordable Care Act that was passed in 2010 but didn't have to be enacted until just in the last few weeks. And the issue is a lot of times patients are brought into the hospital and the doctor might say, we're going to admit you for observation so we can observe you. And patients a lot of times, especially Medicare recipients, think that they are being admitted into the hospital as an inpatient, where in fact they're what's called an observation status, which is an outpatient. It's a billing status. They're really an outpatient. So depending on if they're admitted as an inpatient or for observation depends on whether Medicare Part A or Medicare Part B covers it. So that's why it's really important that we start to talk to Medicare recipients shortly after they're in the hospital, especially if they're observation patients, and explain to them why they need observation and how that's going to possibly impact them financially.
Okay, so I can see where the confusion would come in because the doctor says admitted. So you can be admitted as an inpatient and you can be admitted as an observation or outpatient status.
Correct.
So when a doctor says you're going to be admitted, not necessarily are you an inpatient.
That's right.
Now, the inpatient versus observation, that's been around for a while, a long time.
A long time,
okay.
Yeah.
And you mentioned that this impacts primarily Medicare recipients.
Medicare recipients and Medicare eligible people that might have Medicare Advantage plans.
Okay. And every year when we do the Medicare update, they kind of explain option 1 for Medicare is where a person has their red, white, and blue Medicare card. They might have a supplemental Medigap insurance, and then they might have a Part D plan. That's kind of option 1 for you to get your Medicare. And then option 2 is you have a Medicare Advantage plan where it kind of wraps everything all in one. So it impacts both. It impacts them differently, but it impacts anybody who has Medicare. Okay. So Medicare recipients only. Option 1, option 2. Who determines if somebody's an inpatient or observation? You just flip a coin?
Well,
do you want me to take it?
Actually, your whole healthcare team does.
Okay.
A lot of times you might have come in with something that could be several different things. For instance, like chest pain, or
chest pain, kidney stones, abdominal pain, dehydration, simple things that we don't have a definite cause, and or if you're not sick enough, you can we can take care of you like in 24 hours and get you back home. So that is definitely considered outpatient treatment, not inpatient. It doesn't mean along the way, if you get sicker, that we change you to inpatient if we need to do more. If something changes that now you're sicker, your lab works worse, where initially maybe it wasn't, everything looked normal, and now we're seeing more positive labs, that indicate something is definitely going on, and then we could change you. But until we know for sure what definitely is going on, you're going to be in observation.
Okay. And it's not necessarily the whole healthcare team is part of the decision, and it's a complex decision. It's not like
yes.
You come in with abdominal pain, you're never going to be an inpatient. If your labs or
Right.
whatever everybody looks at,
The ultimate decision comes down to the physician. I mean, it's still physician driven. He just appreciates everybody else's input. From a UR standpoint, just what's going on. Medicare has strict guidelines that it's not just us. Everybody needs to follow these guidelines to help determine whether you're an inpatient or an outpatient. Again, that still doesn't mean if the doctor feels there's a lot more going on and maybe we're just not seeing it. I mean, he still has the ultimate say, and his documentation is going to support, along with what's going on with the patient, his decision for what that need is. But it does involve, like Linda said, pretty much a whole team to oversee it.
And this is something that you've been doing with patients
For a long time.
for a long time.
Long time.
You've kind of been explaining to them
Yes.
your inpatient, your outpatient, all that kind of stuff. But there's a new form, a new magical form.
There is. The new requirement because of the Affordable Care Act is that we provide Medicare patients in writing if they're an observation patient and why they don't meet inpatient criteria at that time. We also have to give them an idea approximately how much they're going to have to pay or what they're responsible for, because if they're observation patient, it uses Medicare Part B, so that covers things differently than their Part A for inpatient does. And so we kind of give them a little bit of information on, for this year, this is Medicare's deductible, they're out of pocket. These might be some tests or procedures that wouldn't be covered. So you might have to pay those. Another really big thing is the medications, because some medications, when you're an outpatient or observation patient, Medicare won't cover if they're considered self-administered meds. So we want to make sure that the patient and their family are aware at that time that this isn't going to be covered as if they were an inpatient, and that has nothing to do with our decision, but it's the way Medicare does it. The one thing I do want to stress is that it doesn't matter whether you're an inpatient or an observation patient, your care is going to be the same. We're going to give you the treatments that you need, the tests you need, the medications you need, regardless of how it's reimbursed by Medicare.
Okay. And so it's not like you're holding them, okay, are they inpatient, are they observation, okay, now we're going to do this, we're going to do that.
It's never going to change their care.
Okay.
That whole inpatient observation is mainly for a billing. It's mainly for billing. It does not at all affect the way the patient is taken care of, not at all.
And that's, I guess I failed to introduce you officially in the beginning. Your title is Utilization Review, and so you are a nurse.
I am.
And you deal with insurance.
Oh, yes.
God bless you. Day in and day out.
Yes.
Just for this reason, you are the liaison kind of between the nurses, the patient, the doctor, and the insurance company, so that everybody dots the I's and crosses the T's.
Hopefully.
So that
And we get reimbursed.
Yeah.
Patients get the best care, we get reimbursed. That's what you have to do.
They don't have any surprise bills,
No,
hopefully,
no.
that kind of
They
stuff.
get surprised when I have to tell them that, did they realize they don't have this benefit? Some of the managed Medicares, people don't understand what they're getting. Managed Medicare means that you've turned your Medicare benefit over to whoever, Anthem, Humana, whoever, and they're using your Medicare benefit. It's all in one. It's like you have a regular insurance using the Medicare benefit. So it just becomes like having a regular insurance. Everything has to get authorized. It's not a given. So they sometimes don't understand what that entails, especially when they need skilled nursing care.
Yeah.
You know, we come into, it has to be authorized. They won't authorize it. They don't understand why. So there is a lot more going on that patients need education because they just don't understand.
And you mentioned in the beginning that it impacts Medicare. People have standard Medicare differently than if they have a managed care plan. And if they have a managed care plan, they're all kind of different, and so
They're all
the
different.
patient or their caregiver or whoever needs to kind of,
They're all
they need to
different.
talk to that advantage.
Some of those managed Medicares, that's the other problem, is some of those automatically give them medicine coverage instead of them getting another Part D. Part D is the part of Medicare that covers your prescriptions. And but some of the managed ones do include the Part D, so again, that's where they get confused. Some of regular Medicare patients, their secondary insurances, some of those cover their prescriptions. It's not universal across the board.
It's gotten pretty
different for
complicated.
every
Every patient is different, and when you try and explain to them what they need to do, they just sometimes just don't understand, because it is very, very confusing. So the best thing is that you understand what you have and what it covers, so that you're not in a quandary when something comes up. You think, oh, I already have that, but you really don't.
Not
So
necessarily.
it not necessarily is right.
And so how, we've kind of tossed around the Part A and Part B and all, so if you're an inpatient, we're billing the Medicare Part A.
Correct.
And if they're an outpatient, we're
They're
billing,
observation.
or I'm sorry, observation.
Which is
we're-
outpatient.
We're billing the Medicare Part B, which pays differently than A.
Yes.
So there might be more co-pays or things like
Out
that.
of pockets, deductibles, stuff like that,
Okay.
depending on what the set rate is by Medicare
Okay.
at January 1st of every year.
Okay.
And then hopefully their secondary, if they're straight Medicare, hopefully their secondary will pick up. Most secondaries follow Medicare guidelines, so sometimes when we had to go in and do the moon letter, some people say, oh yeah, my secondary paid for my, everybody is different. Again, it's not across the board, but hopefully your secondary, that's what you have it for,
Right.
is to help you pick up on things that Medicare doesn't pay for. It's not a guarantee, but hopefully that's what happens.
And do you and Katie and other people, I mean, this is so confusing. And then you think about, I mean, somebody's not well. They're in
No,
the
that's right.
hospital. And
That's
then that's kind of a tough time to learn about what your insurance covers
That's
and
right.
what it doesn't. But, I mean, is that what you guys do? Is
On a daily basis, 24/7, all the time. And hopefully between Katie and I also, when there's family members, we just try to make sure that when we're talking to the patient, that there's a family member there that can help. And a lot of times that's the person that's helping them anyhow.
Right.
And if not, they'll say, well, my son's coming back, and we do. We give them our name and contact number, because it is confusing. And if they've helped them pick this coverage or are trying to help them all along the way, the more that they can understand, then the more that they can make sure they're picking a product that's going to really help them all along. So
and this the moon letter now that they have to sign has to be signed.
within 36 hours, but
Okay.
we've been just routinely, if they're an observation, we've just been trying to get it, I've been trying to get it signed like as soon as I can, so that
Okay.
they're aware any of their self-administered drugs, that's anything taken orally, Medicare will not cover, and that's not anything new, it's been ongoing. It's
Right.
just now they're signing a letter that says they understand that, and reminding them that they can bill their Part D if they do get billed,
Right.
get a bill for the oral. We can't bill it for them, but they can turn around and resubmit it to their Part
To their
D,
Part D,
and hopefully that most of that would be covered. So yeah.
Okay. We're about to take a quick break and switch you out for Katie. Is there any last minute thoughts you wanted to share, or any?
Nothing other than if patients have questions, don't hesitate, even if Jody or Katie or other people working in those positions that day are not available. Ask your nurse to have them stop in and talk to them. There's no question that's a dumb question, and we'll answer it, because
Yep.
we do want our patients to be informed and know what's going on. And this is just another way to do it. We always communicate with them very well, but this is something that we can provide to them in writing, and they can ask questions at that time. They also get a copy of the form after they've signed it that they can take home with them. So it's just another way to communicate. So never hesitate to ask questions.
Especially when it comes to insurance.
And we did give them, along with that form, Linda we did print off some Medicare guidelines from the
Okay.
Medicare website, and just if anybody wants to go and look, if you go to Medicare.com, there's, well,
one's
I printed it Medicare.com
Oh, yeah.
to get this. Medicare.com specifically goes into detail what medical necessity is, et cetera,
Right.
and it gives them examples, which is pertinent to them. So there's a whole lot of information online at Medicare.com or
Okay.
.gov, either one, that can just help them with phone numbers also. So just, and again, we'll be glad to help.
And bringing that up, there are certain websites that are very reliable that will give good information for Medicare recipients. An example of one that's a questionable one is the Center for Medicare Advocacy. I've heard that several Medicare patients recipients have been getting information from this particular agency or group, and they're telling patients in the information they're sending out to them that, you know, you have the right to demand that your doctor makes you an inpatient, and they have to do this, and hospitals are only putting you in observation for a higher reimbursement, and all of that is very false. And so make sure that if you're going to the internet for any type of information that you're using a reliable source. And the Center for Medicare and Medicaid Services is a great one. Medicare.com, which is a government agency, is good. Make sure you're using the right things and asking questions, because some of the things that they might be reading are not true.
Very misleading. They're very misleading.
Thank you, ladies.
All right, thank you.
We're going to take a break and we'll be right back. Talking about inpatient versus observation status. And now we have Katie, the social worker, with Jody, the UR nurse. We talked about how this impacts Medicare patients and the different kinds of Medicare that people might have, kind of the option one, traditional standard Medicare versus Medicare Advantage plans. And I know you guys run into this too, and when I do Medicare comparisons in the fall, I think what confuses people is the company name. Like, I have Anthem. Well, Anthem does a Medicare Advantage plan. They might have a Medicare secondary plan. They probably do prescription plans as well. So
they do.
It's not necessarily the name of the company that your insurance is through, but it's how do you have that insurance? Is it a secondary? Is it an Advantage plan? So you were talking about how sometimes patients don't realize what they have until they're in a healthcare situation and they need to know right away. So you're like the dynamic duo working with patients, trying to help them understand their insurance, usually when they're not feeling too good because they've come to the hospital. And we talked about the inpatient versus observation, the Part A versus Part B. I know one of the big things you do is discharge planning. And so somebody might need to go to a skilled facility after they've been in the hospital for some continued rehab or whatever. Talk about how all of this plays into that discharge plan.
Well, when I do discharge planning, the first thing I want to check is the patient's level of care, if they're observation or inpatient. The observation will affect their Medicare benefit when they go to the nursing facility, because it does not qualify for the inpatient qualifying stay. And at that point, the nursing facility would be private pay on a daily rate if they go from an observation status. If they went from an inpatient status, and they had that qualifying overnight stay, Medicare would cover the nursing facility stay. They have 100 skilled Medicare days. Days 1 through 20 are covered in full. Days 21 through 100, Medicare will pay a portion, and then the secondary insurance will be billed. And the length of stay at a skilled nursing facility really ultimately depends on the patient in relation to Medicare guidelines and their prior level of functioning. So just because they have 100 days or 20 days doesn't mean that they're going to be there for that length of stay.
Right. And it doesn't necessarily, just because Medicare pays for 20 days at a skilled facility, doesn't necessarily, they have to still be skilled. They still have to be receiving therapy or whatever the skilled care is.
Exactly.
And I know also when somebody says, if they are an inpatient and they've been there for 3 days, they've been there from Tuesday through Thursday, that's 3 days, but it's not necessarily 3 days, it's three midnight.
It has to be 3 midnights, absolutely.
So that's kind of an education piece that you guys have to help
Exactly. And also one other thing too, if, like Jody has touched earlier on the segment about, observation and changing patients when they are medically meeting medical necessity to be an inpatient. The inpatient starts from that time of the inpatient order. The observation time does not count towards that inpatient 3-night stay.
Gotcha.
So you have to go from the time the inpatient order was in.
And that only affects, the 3 midnight stay only affects regular Medicare patients. If you're a Medicare Advantage, if you're a managed Medicare product, you can actually, if you have a skilled need and it gets authorized, you can go to a nursing home from an observation status. You don't need any of that 3-day. You could actually go from ER if your managed Medicare would approve it. So that 3 midnight only pertains to straight regular Medicare patients.
Those people with that option 1
Yep, and it has to be when, like Katie said, when they're an inpatient. If they were at observation 2 days and then get changed inpatient, the inpatient starts on that day that they were changed.
Okay.
So,
And you threw a little phrase in there that if they're approved,
and that's a whole nother ball of wax. But when, again, like I said earlier, when you're a managed Medicare product, that insurance is using your Medicare benefit, it's overseeing everything, and they have to authorize you to go an acute inpatient, some outpatient services, and skilled services. They have to authorize that they will give you a length of stay, a number of days that they feel you warrant. You can keep updating that if that's not enough time, but it's not a given with Medicare. If you have the 3 inpatient days and you have a skilled need, that's all we need. We don't have to have somebody give us permission to send you, but you have to have a skilled need by Medicare guidelines. So that is the big difference with regular Medicare and managed Medicare, because people just assume that they can go, and a lot of times their managed Medicare doesn't approve it.
or only approves it for...
Or only like 3 days. It's usually when I'm getting them authorized, we're lucky if they give you 3 days up front because they want to see how the patient does in that skilled level of care, and are they good enough that they can just go home and continue as outpatient. So it's just not a given.
And so you kind of help, you guys are the ones and the nurses that send all the information to the insurance company, the therapy notes, the doctor's notes, the nurse's notes, the lab
usually,
work.
right, based on physical therapy, if it's a therapy need, like if they're weak and just need to get stronger, if they're getting IV antibiotics, or that is also a skilled need as long as they're getting it a couple times a day. So that could help toward getting them skilled, or if they have a lot of wound care that they need. It's not just needing therapy, but that's the big thing, is therapy.
I've been thinking about what Linda mentioned about the flyer from the Center for Medicare Advocacy about how you should demand from your doctor to make you an inpatient, but that could end up hurting the patient in the long run. Well, I don't think a doctor would, but in an off chance that a patient demanded that a physician put them as an inpatient and the doctor did it and everything got sent to the insurance company for billing, they're going to deny it because that was
most
not
likely.
And then the patient's going to be
they could be subject to being
with the
responsible
bill
for some of that. It's just all going to depend on how it falls out.
So that's not
But
super
hopefully,
good advice.
hopefully we wouldn't let that happen.
Right.
I mean, we try it, and the doctor can't just change them, and he would explain that to them because they all understand and they all know. They would explain that to them, and the patient has a right to actually refuse anything too. They have a right to say, you know what, I'm just going to go home and try and do the best I can, and not even do this. So.
So there is a ton of work that has always been going on behind the scenes with faxing information either to a skilled facility or a home health agency, insurance companies all the time, getting therapy notes, all that kind of stuff. Phone calls constantly back and forth, yes. And I appreciate what Linda had mentioned also about, again, a person is not feeling well, that's why they're in the hospital, and this is so confusing, and they can ask you guys, and if it's a billing question that's beyond what you usually work with, there's other people that could help them.
Yes. Usually we call, Jody and I try to do a fair job, good job actually.
Excellent job.
Getting in contact with, the appropriate people that may be able to assist. We do have the financial counselor or counseling department that is available to answer, any additional questions that we may not be able to. And just going back and touching on discharge planning, that's what I do at the hospital. Keep in mind, if you go home with home health services and you need, home health, observation versus inpatient, it doesn't matter. You can get some home health services as long as there's a skilled need there, such as therapy, wound care, nursing
med
care,
management.
med management, you name it. And also with like medical equipment as well, observation versus inpatient has no effect there. You can get it as long as there is a need for the medical equipment. The doctor writes a script and also doing a face-to-face, just qualifying the individual for that DME, durable medical equipment item. Okay.
Again, more work going on in the background.
Yes.
And just so patients understand, if they do get hooked up with home health, that whoever's coming in, the agency, patients should always ask if they're still concerned. That healthcare provider, whoever home health, can answer questions, or if something comes up and they're concerned, they can call their doctor. They should never just feel that nobody's going to help them, because they should just follow that chain. And if worse come to worse, call their doctor's office and go back.
Right. Because that's all the other topics we, for many years, done on the show about health have always been about, diabetes or heart disease, but so much more is now about insurance, because that's how people pay for that health care, but it also impacts them from stress level of, I don't understand what I have and I got this bill, so.
Well, and that's another point we should make, because at Magruder Hospital, our patients always come first, and if I have to keep on the insurances, we will, we're going to do our best to take care of our patients, and even if the insurance doesn't agree, the doctor is going to do what's best for the patient first. And yes, we're going to worry about that on the sideline, but it's not going to compromise the patient's care. Absolutely not. They're always going to come first.
Some of the information that we've been handing out at some of the educational things have some scenarios. So I'm going to pick one.
Okay.
Just somebody might be going through that, or know somebody who is. So if they're in the emergency department or the emergency room, and they're admitted to the hospital with a doctor's order. So in the emergency room, they are outpatient. That's the Medicare Part B stuff. But if they're admitted as an inpatient, then that's Medicare Part A. But if they come through the emergency room and they have abdominal pain or something like that, dehydration like you mentioned before, and the doctor says, I'm going to admit you as inpatient or
and
observation.
That's where the confusion starts, because when they say admit, I think patients just hear admit, not realizing your status is going to be observation or inpatient.
There's two options for that admission.
And I know they've been trying to make sure they say you're going to go up as an observation or an inpatient. And if they do come up as an obs and they're not aware, they will be aware, because I'm going to be in there with that mood letter and we're going to talk about it. So they're going to hopefully understand. And the doctors are really good about saying that to them also when they make their rounds, reminding them that hopefully you're already feeling better. Hopefully we're going to get you out later today. So it's ongoing.
And you had mentioned if somebody comes up and they're admitted as an observation status, and they do more lab work or they do more testing, and the patient is getting worse. I don't know, fever, IV, I don't know, that's all what you guys figure out. They could change.
Yes. They started as abdominal pain and we didn't have enough to support what was causing this abdominal pain. Well, now we've done a CAT scan and now their labs are all worsening, indicating possibly a pancreatitis, and a CT scan now is supporting that also. Well, they're definitely sick and they're probably definitely going to need more than 2 days, so they're going to more than likely be sick enough to be considered acute, and we could change them. The doctor's probably going to want to change them to an acute inpatient, not with abdominal pain, now with pancreatitis.
So they won't be inpatient from the moment they got up to the patient floor.
It's going to be when he changes that order.
Whether that's the next day or later that day, doesn't matter.
And if it is that same day, then that kind of changes everything, because it would just be inpatient for that day.
Then they might, if they need further care after the hospital, then they maybe have been inpatient for those 3 days. Okay. So if you go to a hospital for outpatient surgery, but they keep you overnight for high blood pressure, your doctor doesn't write an order to admit you as an inpatient and you go home the next day. You're not an inpatient.
No, you're not.
You're an outpatient for the surgery, as it mentioned. You're there for outpatient surgery. And even though you're in the hospital overnight, you're just being observed for that high blood
You're
pressure.
most likely gone to an observation status, which is still outpatient because we're just observing, making sure your blood pressure normalizes or that we don't need to do something else with it. And again, you're going to be constantly monitored so that if something does change, that we need to change your status, then we will.
Okay. So there's countless scenarios I'm sure that you guys have seen come in observation. Does anybody start as inpatient and go to observation?
Mostly patients that have something acute right off the bat, like if they're going to need a bowel surgery, like a bowel obstruction, people that are scheduled for surgeries, total hip replacement, total knee replacements, those automatically start acute inpatient. If somebody comes in with, and they diagnose them like as a pancreatitis right up front, they're really sick, those people usually don't even eat anything for a couple, it just depends. But those main things, if somebody's going to go to surgery for something acute, that's
and it's not up to us to know. That's what Linda had mentioned. There's a whole healthcare team. There's everybody in the ER. There's lab. There's radiology. There's the nurses, the doctors.
And we all work together.
We all work together. Yep.
Determine the appropriate level of care and discharge needs afterwards.
Any final thoughts on all of this lovely topic?
It's never ending. It's constantly changing. Just
but
be
if you have
right.
questions, feel free to give us a call at the hospital. Jody or myself, we're always available. If we don't answer, we'll call you back and be able to, get an answer for you or get a person that can answer.
Just be aware of what you have.
Yeah.
Just be aware as much as you can what you have. It's sometimes so misleading, and when you find out you don't have what you think you do, it's sometimes you're not in a good place to deal with it. So just be sure when you sign for something that you understand what you're getting, and maybe a family member's there to help you, because it is very confusing. The wording is very confusing. I've done this job, dealt with it for 17 years, and sometimes I still get confused when I look at things. I'm like, oh my God, I can't always understand it. How are these people understanding it if somebody isn't explaining it? So just understand. Ask questions. Never a wrong question.
Yes.
Okay. Awesome. Thank you, ladies.
You're welcome.
Thank
you.
We're going to take another break and we'll be right back. I want to thank Linda and Jody and Katie for being our guests today. Learning a lot about a kind of a background, somewhat confusing topic, but as you heard all of them suggest, it's very important. Don't be afraid to ask questions. It's very confusing. There's lots of resources out there. In fact, one of our goals is to get out and educate people as much as we can about this topic, so you can actually call me at the hospital. And my direct line is 419-732-4061 if you want somebody to come and speak to a group or share more information about this topic. If you ever have feedback about a program or a suggestion for a future episode, you can let us know by sending a note to Time for Health, 615 Fulton Street, Port Clinton, Ohio, 43452, or you can email Mrs. Pelz at the high school, cpelz@pccsd-k12.net. So think about something you learned today, whether it impacts you or somebody you know. Be sure to share the information, and until we meet again, I encourage you to make time for health.